Good morning, everyone, and Happy New Year to all of you. This is the first session we offer in the new year from the Occupational Health Center. Today's the topic is about result from the Manitoba Occupational Disease Surveillance System. We are so pleased to have Dr. Aaron Kraut. He is the Associate Professor at the University of Manitoba, Departments of Internal Medicine and Community Health Sciences. Dr. Kraut has also has practiced clinical occupational medicine in Winnipeg, both at the Health Science Center and the Occupational Health Center here. He has been attending physician as an attending physician on the internal medicine clinical teaching units at the Health Science Center for 30 years. Dr. Kraut is also the medical director at the Occupational Health Winnipeg Regional Health Authorities in the greater site. So before we start for the presentation, we would like to acknowledge that we are together here in Treaty 1 territories, and that Manitoba is located on the territories of the Anishinaabe, on Sunniwik, Dakota Oyate, in the Sununi, in the Lukwick, the Nakatupa nations, and on the national homelands of the Red River Métis Nation. We acknowledge that Northern Manitoba includes territories of the Inuit. As we gather on Treaty 1 territory, we also recognize Treaty 3 territory, in particular Salt Lake 40 First Nation, the source of Winnipeg's clean drinking water. We also acknowledge Treaty 5 territory, including Nelson River, which provides us with access to most of our electricity. The Occupational Health Center acknowledges the devastating, lasting, and ongoing impact of settler colonialism on Indigenous people and a deep lack of action towards truth and reconciliation. OHC here has embarked on the process of learning about Indigenous peoples, history, and culture, and our role as settlers with our staff, the board, and the volunteers under the guidance of the knowledge keeper Clayton Sandy. We commit ourselves to active accountability, truth, justice, equity, and reconciliations. For some of the folks haven't been to our webinar, please notice that we are going to recording this webinar and going to share with you on the social media and also the link. Then you could watch it over and share with your friends and some people you think is interested in this topic. And Dr. Kraut will be answer the questions right after his presentation. Please put your comment and the question on the chat box here. And also, in some of the people doesn't know about OHC, we would just like to let you know that OHC is the Community Health Center funded by the Winnipeg Regional Health Authorities. We are the Community Health Center. We're located on 167 Sherbrooke Street, Winnipeg, Manitoba. We provide the services to the Manitoba workers with work-related health issues and work closely with the Joint Workplace Health and Safety Committees for training. So our service is free. Please visit our website, ohcmb.ca, for more information and resources. Now, this is the time to join me to welcome Dr. Kraut for his presentation.
Okay. Thank you, Tiffany. Can you hear me okay?
Yes.
Okay, great. Okay, so thank you very much. It's always a pleasure to present to this group. And what I'm going to be doing is sharing some of the results from a research project that I was fortunate enough to get funded by the ARWA program at the WCB. So I'll start with some conflicts of interest. As Tiffany mentioned, I have a position at the university. I'm also the medical director for Shared Health for Occupational Health, WRHA, Health Sciences Center, St. Boniface Hospital. I work at the MFL Occupational Health Clinic here and have been seeing people for well over 30 years now here. And this, as I mentioned, this work was funded by a grant from the ARWA program from the WCB of Manitoba. So the the objectives, what I'd like to talk about is how we set up the Manitoba Occupational Disease Surveillance System. And most of the talk's going to revolve around carpal tunnel syndrome and how we used that system to identify jobs and industries at increased risk for carpal tunnel. We're going to also, at the end, just briefly describe some of our other work, looking at acute heart attacks, asthma, and contact dermatitis. And then I'm going to talk, and throughout the talk, there'll be some talk on the limitations and strengths of linking WCB data to health data in the study of a variety of health conditions. So when one looks at occupational epidemiology, there's a number of major sort of types of studies that one does. The first is cohort studies. And in a cohort study, you basically identify a group of workers who are doing the same thing. And then you follow them over time, and you look for a variety of disease outcomes. Now, the limitation here is that you're looking at one group of workers who have only one type of, or one or a few types of exposures, but you can look at multiple outcomes. Another type of study that's commonly used is case control studies, where you start with people who have a single outcome, like let's say a certain type of cancer or whatever, and then you look back and see what they were exposed to. The limitation here again is that you're only looking at one outcome. Both of these studies types of studies are time consuming and fairly expensive. Another way to do this is linkage studies. And when you do linkage, what you do is you sort of link some administrative data. And here we have access to population-based health data, sort of physician billing data with diagnoses and hospitalizations with diagnoses. And then you link that with some type of exposure data. And the most common one is job title. And you can get that either from, in some countries, census, in some places, census data or income tax data. And here we have access to WCB data to get job title. Now, WCB data, if you use that for exposure data, it gives you a job title, it gives you industry, and it gives you a date of a claim. The WCB Manitoba codes only codes occupation for time loss claims only. So with that data claim, you'll know that the person was doing that job at that specific date, and then you can create a window of time around that where you're comfortable that the person's really doing the same work. If the window is very narrow, so you're more sure that the person's doing the same job, that gives you a limited follow-up. And if it's too wide, then you have longer follow-up, but you're uncertain really if the person is doing the same job. So you have to sort of come up with a window where you're more comfortable that the job hasn't changed. And I'll talk a little bit of what we did here. Now, this kind of work was done before. The first people to do this work was Nicola Cherry and her group in Alberta, really just over 15 years ago, where they looked at asthma. And in Ontario, they have quite a developed system looking at this. And there's been a number of publications for a number of years now. Here I've cited lung cancer and heart attacks in Ontario. So how did we set this up? Well, in Manitoba, we have the provincial health system. We're able to link the physician billing claim data, which has diagnosis and hospital data, with WCB time loss claim data. And in the administrative data for Manitoba Health, it's stored in the Manitoba Centre for Health Policy. It's all de-identified, so there's no names in it, and the actual health number is replaced by a pseudo-FIN number. So it's not a real FIN number, it's a pseudo-FIN, and they have some formula where they calculate pseudo-FINs. Manitoba, we've got a population of around 1.4 million people. The WCB, we have a diverse economy, and the WCB covers about 77% of the provincial workforce. People that aren't covered are self-employed, farmers and teachers. and it's the sole provider of compensation services in the province. Most of, I think almost all the industrial workers are in fact are covered, but someone can correct me if that's not quite right. So what do we do here? Well, first, after we had funding and we went through all the legal and ethical hoops, the WCB prepared 2 files for us. The first one had a WCB identifier and all the personal identifiers, name, address, date of birth, sex, and FIN number, actual FIN number. And then it prepared a second file where it had the WCB identifier and all the claim information, sort of date of injury, type of injury, occupation, etc., but with no personal identifiers. So the WCB sent the first file to Manitoba Health, where Manitoba Health linked it to the pseudo-FIN that they'd created based on the actual FIN number, name, date of birth, sex, and postal code, and the linkage was very good, well over 95%. And then it created a third file with the WCB identifier and the pseudo-FIN. So the WCB sent its second file with all the occupational information to Manitoba Health, to Manitoba Center for Health Policy, sorry. And Manitoba Health sent their file that they created with the WCB identifier and the pseudo-FIN to the Manitoba Center for Health Policy. And then at Manitoba Center, both files were linked based on the WCB identifier. So now we have a file that has all the WCB data linked to the pseudo-FIN, and then the health data and the WCB data were linked via the pseudo-FIN. So that's how we sort of created this. So there's a fair bit of computer work involved, but once we had the right permissions, it went reasonably well. So I'll give you an example. So this is for carpal tunnel syndrome. This is work we did. So when we started, we had claims from the January 1st, 2006 to the end of 2019. And in total, there was just under 214,000 WCB time loss claims. So we eliminated those claims that didn't have occupational codes, 2,342, those that couldn't be linked, just over 9,500. Now, many, but I think when I looked before, it was about 3% of WCB claims in Manitoba from people who are outside the province. So obviously they're not going to link. So overall, we linked well over 95%, which is pretty good. We also eliminated claims where there was a repeat person-occupational combination. For example, if a plumber had one claim 1 year for a back injury and then a second claim for contact dermatitis, let's say, we only included the first claim. So, but if that same person, well, let's say they started off being a plumber and they had their back injury and then they became something else and they had a second claim, they were counted twice. So we have person-occupation combinations. We also eliminated people who had no health coverage for 3 years prior to their injury date, just because we wanted to go back in time and see whether we could identify previous cases of carpal tunnel syndrome. And we eliminated workers under age 15. I was quite surprised to see that there are 46 people, 46 children really, that had a time loss workers compensation claim. Anyways, at the end, we were left with just under 145,000 workers over age 15. And then we excluded people who had a diagnosis of carpal tunnel syndrome within 3 years prior to when we started the study. And I'll talk about that in the next slide, because we only wanted to look at really new cases of carpal tunnel syndrome. And there are almost 2,000 of those. So we're left with just over 143,000 person-occupation combinations, which were over 115,000 individuals and 485 occupations. So this is an outline of the actual way we did the study. So we had a date of injury here, And we knew that they were in whatever occupation they were injured at this time. So we assumed that for the 2 years prior and the 3 years after, they were likely doing the same work. And that's our study period. They had this washout period of 3 years before. So if they had a diagnosis of carpal tunnel syndrome in here, we eliminated them because we weren't sure they were actually doing the same work. That's roughly how we set things up. The outcome measure of carpal tunnel syndrome was at least 2 physician billing claims for ICD-9-354, which is mononeuropathy of the upper limb, which includes carpal tunnel syndrome in a 12-month period, or a surgical claim for a median nerve release, which is the treatment for surgical treatment for carpal tunnel syndrome. And again, they had to be within 2 years prior to 3 years following the time loss WCB claim, which was our index date. We also included individuals who had accepted WCB time loss claims for carpal tunnel syndrome, but weren't identified in the medical claims data, so that we would actually get all the workers who were diagnosed with carpal tunnel syndrome. We followed workers until they were diagnosed with carpal tunnel syndrome. They left the province, died, end of the 3-year follow-up period, or end of the study date, which was March 31st, 2020, whichever came first. The way we measured exposure was we looked at basically industry and occupation. And industry was coded using the system that the WCB uses, which I think is common throughout WCBs in Canada. And it has a sector and a subsector. Occupation was coded according to the National Occupational Classification 2016 version, which was developed by Statistics Canada. And again, these are hierarchical schemes. For industry, we presented sector and subsector data. And for occupation, it goes at an overall level, a 2-digit level, a 3-digit level, and a 4-digit level, which as the numbers go up, the occupation becomes more specific. Our analysis, we looked at Cox proportional hazard regression, and we compared the hazard ratios for carpal tunnel syndrome for each industry or occupational subcohort to everybody that wasn't in that, adjusted for age and sex. So that points out that the comparisons groups weren't exactly the same for every comparison, but they were quite similar. Manitoba Center doesn't allow us to present results for groups that are over 5 individuals. And then we repeated the analysis again, excluding cases of carpal tunnel syndrome that were accepted by the board to see if, or time loss claims that were accepted by the board to see if any increased risks that we had observed disappear after excluding the WCB cases. We had approval from the University Ethics Board and the HIPC committee. Just a little bit about carpal tunnel syndrome. So here we see the carpal tunnel, the median nerve, and it passes under the carpal tunnel, the transverse carpal ligament. And this is the area where causes problems. And surgical treatment is cutting the carpal ligament. And here you can see a case of carpal tunnel syndrome where there's severe wasting of the muscles of the thumb on this side and that side. This person had it in both hands. So carpal tunnel syndrome is quite common. It's between 3 to 6% of the general population. It's the most commonly diagnosed peripheral nerve entrapment syndrome, and it's associated with a large number of compensation claims. Some of the risks, risk factors, women are at a greater risk, people with diabetes or hypothyroidism are at increased risk, oral contraceptive use increases the risk, being pregnant increases risk, obesity, trauma to the wrist, and arthritis are other risk factors. Most of these things lead to sort of narrowing of the carpal tunnel, either by swelling or edema. Workplace factors that are commonly associated with carpal tunnel syndrome include using high force and working in awkward positions, doing repetitive work, and vibration are the 2 most common causes. Okay, so specifically what we were looking at here is we examined the relationship between carpal tunnel syndrome and work. We sought to identify works, job titles and occupations with an increased risk of carpal tunnel syndrome. We wanted to see whether there's a sex difference after controlling for occupation. And we wanted to see if any of the observations that we had persisted after excluding time accepted CTS time loss WCB claims. So what did we find? Well, I think there were over 4,300 cases of carpal tunnel syndrome, and here we can look at men and women, and you can see as age goes up, generally the rate of the risk of carpal tunnel syndrome goes up, except for the highest age group here. Generally, it goes up with age, and it's higher in women, 3.92, than in men. So age and sex are important factors to control for when you're looking at this data. In total, we had over 4,300 cases of carpal tunnel syndrome. 3,236 were identified in the medical claims alone, and there was 1,066 WCB claims, which is roughly a quarter, which I thought was pretty high. Of the WCB claims, 591 were also identified in the medical claims, giving a total medical claims of 3,827, and there were 475 that were only identified in the WCB data. These would be individuals who maybe presented and their doctor diagnosed them with hand pain instead of carpal tunnel syndrome initially, and then got nerve conduction testing, and then had applied for, and then the person applied for WCB coverage. So we wouldn't have picked them up because they didn't have an official diagnosis of carpal tunnel syndrome in the medical claims. So again, the total was just over 4,300. Now, just to go over the hazard ratios are a measure of risk. And if the hazard ratio is 1, it means the risk in the exposed is the same as that in the unexposed. If the hazard ratio is 2, the risk in the exposed is twice that in the unexposed. And if the hazard ratio is 0.5, it's half that, okay? And if the 95% confidence intervals exclude 1, the association is felt to be statistically significant. So what do we find here? Well, this is by looking at industries, and the bold are sectors, and the non-bold, the plain text, are subsectors. So in healthcare, there are 702 carpal tunnel cases, but the hazard ratio was 0.74, so it wasn't, and it's not elevated. In manufacturing, though, over 1,000 cases, 1.52, so 50% excess, significant. And then in the subsectors, aircraft manufacturing and repair, 1.93, so almost twice as high. Textile manufacturing, 1.88. Meat processing, almost 3.48, so almost 3.5 times as high. Natural resources was high at 1.61, and the subsector of mining was 2.5, so that's 2.5 times. Public administration was lower. Service industries were lower, except for the automotive-related section, which was higher. Now, one of the reviewers questioned our results because he calculated, based on our data, an unadjusted odds ratio for healthcare of 1.07, and he said, like, you're presenting 0.74. I don't think that makes sense. So if you remember, I told you before that carpal tunnel syndrome was related to age and sex. And if you compare healthcare workers to all others, you can see that the vast majority of healthcare workers with time loss claims were female, almost 85% versus 26% in others. And the age of injury in healthcare workers was almost 43 years versus 39 for all others. So one has to adjust for these factors. And when we did that, so we did, to answer the reviewer's question, we created 3 models. The first was unadjusted, and in fact, we got the same thing that he did, 1.07. When he adjusted for age, it was 0.96. And when we adjusted for age and sex, it fell to 0.074, which is what we reported, statistically significant. So it points out the importance of adjusting for these types of factors. Now, with respect to occupation, the National Occupational Classification categories go from 0 to 9, and these are the major categories. Management's 0, and manufacturing utilities is 9. And there's a bit of a gradient in socioeconomic status from lower to higher numbers here. So we found that most of the occupations with lower hazard ratios were in major categories 0 to 5, which do encompass many of the higher socioeconomic status jobs. But higher hazard ratios were frequently observed in major categories of sales and service, trade, natural resources, and manufacturing. So more of the physical, mostly physical jobs. And just to give you some actual job titles, so those with lower hazard ratios, so nurses have lower ratios, ambulance attendants lower ratios, paraprofessionals and legal paraprofessionals lower ratios, social workers, social service workers lower, police were lower, home support workers were lower, and occupations in the arts, culture, recreation, and sports were, in fact, this was the lowest number we saw. When we looked at which are higher, so here I've just summarized the jobs that had hazard ratios above 2, so twice as high as expected, and there were more than 10 cases. And you see butchers and meat cutters, bakers, millwrights, mechanics, heavy-duty mechanics, industrial miners, underground miners, development miners, industrial sewing machine operators, process control operators in beverage processing, again, butchers and meat cutters, binding and finishing operators, which was overall the highest number we saw, aircraft assemblers, and laborers in fish processing. And all these jobs have forceful, for the most part, either forceful repetitive work or vibration, which are two known risk factors for carpal tunnel syndrome. When we looked at low force, high frequency work like typing, we didn't find any excess of carpal tunnel syndrome in secretaries, office clerks, or switchboard operators. So again, there's no increase if there's low force but high frequency work. Looking at sex differences, it was interesting, we talked before about health occupations having an overall lower rate, a risk. When you compare men and the women, so this is men compared to men and women compared to women. So you can see that they're both lower, but again, men have a lower carpal tunnel risk than women, even after this is controlling for sex in the same occupations. Manufacturing utilities, the same, men lower than women. Manufacturing, again, women have higher. Fish binding and finishing operators, 5.87 for women. There weren't enough men to report here. Assemblers, again, women are higher, and other laborers, women are again higher than men. So why might that be? Well, first of all, we have to know that within the same job title, men and women may be doing different tasks. So there could be higher risks of women because they could be doing tasks that are higher force and more repetitive than men. Another reason might be that for jobs, particularly non-traditional jobs held by women, they might not be designed for female workers, so they could be working in positions or with tools that increase their exposure to ergonomic hazards. Could be the women are more likely to seek care than men, so they're more likely to get diagnosed. Or there could be true differences in risk based on biology. So what happened when we removed the WCB cases on our results? Well, we looked at occupations that had more than 5 WCB accepted cases and elevated hazard ratios. And the thinking was that if the WCB time loss claims identified all of the increased risk in that occupation, when we eliminate the WCB claims, there should be no increased risks remaining in that occupation. So what we found was that the hazard ratios generally declined with the removal of time loss accepted WCB cases, but the increased risk for a variety of occupations still remained, although at a lower level. And just to sort of go through this, so for meat processing industry, overall there were 134 claims, and their hazard ratio was 3.48 starting. After we eliminated the WCB claims, there were still 60 cases, so there were 74 that were accepted time loss WCB claims. But even after eliminating the accepted WCB time loss claims, the hazard ratio for meat processing was still elevated at 2.11, and the accepted time loss claims for WCB, they accepted about 55% of the individuals who worked in meat processing who had carpal tunnel syndrome. For mining, again, it was from 60 to 25. The hazard ratio was just no longer significant, but still 1.46. Heavy-duty mechanics, there were 66 at the start with an elevated ratio, 33 after we eliminated it. So WCB compensated about 50%. The hazard ratio fell from 2.1 to 1.47. Industrial butchers, this is the highest percentage of WCB time loss claims accepted, were 63%. So again, just over a third weren't accepted. And there were 15 cases still elevated at 1.67, and the other ones are similar. So the WCB accepted for these various occupations ranging from 16 to 63%. So when we removed individuals who had accepted time loss claims for CTS, overall, it didn't affect the relationship between job title and CTS health claims diagnosis for many occupations and industries, although they tended to fall. Many high-risk occupations continue to have elevated hazard ratios after removing the WCB accepted cases, albeit with lower risks. And we found that a large amount of the CTS morbidity in these jobs were not identified by using WCB time loss claims. Now, we don't know if the additional cases that we identified in the medical claims were not reported to the WCB, were reported to the WCB but had their claim denied, or in fact had an accepted non-time loss claim by the WCB. So that's one of the limitations of this work. So in summary, with respect to carpal tunnel syndrome based on health claims varied considerably with occupation. So it went from a low of 0.21 in occupations in arts, culture, recreation, and sport to a high of 5.87 in female binding and finishing operators. So that's almost a 30-fold difference, or over a 30-fold difference. And that these wide ranges suggested that occupational factors or factors closely associated with occupation play an important causative role in the development of carpal tunnel syndrome in working populations. Also, we found that occupations where workers use high force and working in awkward positions and doing repetitive tasks or vibrations were associated with CTS, and that's been shown in the literature. We found elevated risk of carpal tunnel syndrome in meat processing and poultry processing jobs, mining occupations, and a variety of manufacturing occupations. And that consistent with that, occupations that weren't associated with those factors, such as social workers, childhood educators, and police, had lower risks of carpal tunnel syndrome. Now, there's a large number of limitations to this work. First of all, we're using job title to estimate exposure. And as we all know, all individuals with the same job title don't actually do the same work and don't have similar exposures. Individuals may not have been working at the same job when they're diagnosed with carpal tunnel syndrome when they had their time loss claim. We try to adjust for that by limiting the time window around the claim to 2 years before to 3 years after. Although the data set included over 140,000 person occupation combinations, When you get down to the 4-digit occupational level, many had 100 or fewer workers. So and then if you need more than 5 cases of carpal tunnel syndrome, so a lot of occupations we couldn't look at who may have been at higher risk. We could only analyze those occupations that had a large number of WCB time loss claims. Also, physicians might be more likely to diagnose carpal tunnel syndrome in individuals who have hand pain or numbness in occupations that they perceive at high risk. For example, if someone comes in and they're a butcher and they have hand pain, the doctor might be more likely to diagnose them with carpal tunnel syndrome when it might be something else. So to get around that, we did require 2 diagnoses as opposed to 1 to try to increase the diagnostic certainty. We didn't require surgery or confirmation with nerve conduction tests to define a case of carpal tunnel syndrome. Also, we used ICD-9 3.54, which includes other mononeuropathies of the upper limb. For more recent years, we did have ICD-9 10, and when we looked at that, about 86% of the people with ICD-9 coded 3.54 did in fact have carpal tunnel syndrome, and 11% had ulnar neuropathy, which has similar occupational risk factors. So I don't think that's a major limitation. We didn't include any information on traditional risk factors like diabetes or hypertension or pregnancy, pregnancy or oral contraceptive use. We didn't control for education, income, socioeconomic status, or race, but occupation sort of correlates with many of these things. So I don't think that's as much of an issue as it's a major issue. And then finally, we had many comparisons. So some of the things we observed could have been due to chance. Okay, some of the strengths. Well, what we found is really consistent with known risk factors for carpal tunnel syndrome, so that gives it some face validity. And this allowed us to create a data set that allows for the exploration of potential health associations between work and a variety of health outcomes that wasn't previously available. Also, this work it's relatively inexpensive to do this once the primary data is collected. You know, I think I have a cousin that was a potter, and I once asked her, how long does it take you to make a vase? And she said, well, if you want to know how long it takes to take a vase, it depends. If you ask me how long is I'm just sitting and forming it on my potter's wheel, it's like an hour and a half, whatever it is. But how long to learn how to make a pot, that took years. And this is also what I say relatively inexpensive, because a lot of cost goes into setting up the health data so it can get analyzed, the WCB data that can analyze. But the inexpensive part is actually linking the two. And you can get a lot more information out of linking it at not that much more money, because you do have to collect all the other data. So these are the people that worked with me on the project. Cheryl Peters was a co-investigator. Elizabeth Riz was our sort of project manager. Randy did all the analysis at the Manitoba Center for Health Policy. And Paul Demers is involved with the Ontario Disease Surveillance System. And we had a lot of discussions on how to do the analysis and how to write up our results. So that's on carpal tunnel syndrome. I'm briefly, just have one slide on each of the others. We did similar work looking at contact dermatitis with mostly the similar team. And in contact dermatitis, we found that manufacturing had an elevated risk, heavy metalworking elevated risk, manufacturing and medication was an elevated risk. Parole officers had an elevated risk. Assemblers elevated risk, metalworking and forging operators had an elevated risk. So some of these workers in this study, some had clearly known risk factors, and some were so it wasn't clear why they came up. We looked at asthma, and in asthma, again, we found elevated risks in veterinary healthcare technologists, fish processing workers, tool operators, gas station attendants, drivers, cleaners and janitors, maintenance laborers, mine laborers, and crane operators, and decreased risks in nurses and residential and commercial installer and services. Again, many of these workers are exposed either to allergens or irritants, which can explain their increased risk of asthma. And finally, we looked at heart attacks. And interestingly, in the transportation industry, we found that transport and heavy equipment operators had increased risk at 1.48. When we further defined it to motor vehicle and transit drivers, again, elevated 1.5, so about a 50% increase. And mail transport truck drivers, 1.56, and taxi operators, in fact, had a high rate of 3.66, so over 3.5 times the risk. And that's what I have. So now I'm going to stop sharing my screen.
Thank you, Dr. Kraut. This is a really, really great informative presentation you share with us. This is a really great WCB outreach project, right? So we would love to asking the folks here to put your question and comment on the chat. So far, we don't have any yet. Yeah, we may want to give guys a couple minutes and see you have any questions for Dr. Kraut.
A lot of numbers.
Okay.
Okay, I'm just looking at the chat. Someone asked how we arrived at the 5-year window around the occupation. Well, to be honest, it's a bit arbitrary. We wanted, we were balancing between wanting to have a small enough window that we thought the person was using would be in the same job, with a big enough window that we would have enough time to analyze. And that's why we picked up, that's why we picked the 5 years. Some of the other work, like the heart attack work, we didn't use 5 years. We used any time after their injury. And then the issue of whether the person's actually doing the same job becomes more relevant because there's a longer time period. So I admit it is arbitrary, but you have to pick something, right? I mean, if we picked 6 months on either side, we probably wouldn't have had any cases of carpal tunnel syndrome because we required 2 claims within a year. So that's why we did that.
Yeah. Another question is about any data with the pet grooming industry.
Pet, I think, well, we talked about, I think we talked in, I'm not sure it was the, I can't remember off the asthma, and one of the asthma and the carpal tunnel syndrome was increased in, or not, asthma and contact dermatitis was increased in vets people. Some, pet grooming, I don't know, if first of all, to study an occupation, you have to have enough people with time loss claims from that occupation. As you get more specific, you have smaller numbers, and then we might not have had enough pet groomers to study. So, I mean, I don't know off the top of my head, but some of them are pretty specific.
Another question is, will this work continue looking into other injury types, like, for example, psychological injuries, for example?
Well, our grant was finished, so this was what we said we'd like to do. I would be interested in continuing this. In the past, there was some talk with Manitoba, with workplace, or not, I think it was workplace, not shared health. It was workplace, not, it was, I believe it was workplace, about them taking over this kind of work and them doing some of it. I haven't heard whether they're going to continue, and if there are people on this call that want this work to continue, speaking to the powers that be might be useful, and I would certainly be agreeable to continuing it and updating it. I know in Ontario, they do have funding. The group that does this has ongoing funding to do data here. So Geeta's asking whether CTS is repetitive strain or muscular strain. Well, I would call it a repetitive strain injury because it's not a muscle injury.
Another information is asking, can you provide more details about how you dealt with sex, gender, and why? And given the explanation you had about why women show up more often.
Well, why we controlled for sex was at the beginning, I showed you that women are more likely to have carpal tunnel syndrome. If you look at, like, in general, women are more likely, and there's some risk factors for women that show up. Pregnancy, for example, is obviously something that women can have that men don't have. Why women show up more? I think that's something that needs a bit more work in certainly people doing the same job. It may be that the job isn't real, there's differences between men and women. Men are bigger than women, and women, the positions and the equipment might not be designed for women. The other possibility is that within the job title, that maybe men are assigned to the heavier job, like more lifting and carrying work, and therefore the more precision and repetitive work with some forces is left to women. And that could be a reason that more women show up in the same job title.
Mm-hmm. Another question is, so when it shows the industry have increased risk for the carpal tunnel syndrome, are there any recommendation made or changes in job process to help mitigate the exposure?
Okay.
Industry
So,
speed analysis.
So certainly, our work was designed to identify the jobs. I think that once a job is identified as having an increased risk, then one has to do what the question suggested. I think one has to come up with determine, well, why is there an increased risk in that job? What are the ergonomic factors that that lead to that increased risk, and then alleviating those factors.
Mm-hmm. Another question from Andrew. Any thought on worker having diagnosis and then a period of light duties of changing?
Sorry, do you want to say that? Maybe I can go back. Can I go back to the?
No, the second last from the chat here.
Okay, hold on.
Any thought on a worker having a diagnosis and then a period of light duties or changing jobs?
Working and then a period of light duties or changing jobs.
Mm-hmm.
Well, I think once someone's diagnosed with carpal tunnel syndrome, and if they're in a job that has all the risk factors for it, I think that job has to be modified for either in general or specifically for that person, which would mean that they should be doing something else. I think that taking someone off of work when they can do other activities isn't in their best interests. So I think that getting light duties, changing over is probably a good thing to do, but then sort of after the thing settles down a little bit, then sort of putting them back in the same job that caused the problems before, it will likely recur unless something else has been modified.
So we cover all the questions so far on the chat. Is there more question or comment? Okay, another one come up. One thing I think I missed or misunderstood was how occupation was determined for the medical only the.
So occupation, we got occupation from the WCB claims. So the person had, you know, when whatever their WCB injury was, a back injury, whatever it was, they were identified as a plumber, pipe fitter, whatever. And then we linked that with the medical claims. So that's how we found occupation. You don't get occupation through the medical claims.
Okay, another question come up.
So all four papers that I cited have been published. So the information's online, and I'm willing to, we can make a PDF of my slides and Tiffany can share them.
Yeah, I could share the slide with the recorded link for all of you. So,
Anything else?
any more questions for Dr. Kraut before we wrap up the session? But in the meantime, on behalf of the Occupational Center, again, thank you, Dr. Kraut, for that really great informative session and the great presentation and sharing your knowledge, you know, in this area, and your research project is really good project, right? And then and also thank you everyone attending and put out lots of great comment and questions on the chat. So we will give another minute for the folks if you have any more questions to Dr. Kraut, and then otherwise we'll be just closing the session.
Okay, thank you folks very
Thank
much.
you. So I will be sending the recorded link and the presentation slide in PDF format to all of you. So have a great day and stay warm, everyone. Take care. Bye-bye.